This is Dr. Stephen Harris. Pharmacology Section 7 will cover drugs used in blood disorders. In Chapter 1, we're going to cover the very important anticoagulants. This chapter starts with an overview of the coagulation cascade. We're going to look at the various components of this cascade, and importantly, we're going to cover exactly where drugs like warfarin and heparin are going to work in this pathway. In this diagram, we're going to look at the clotting cascade, and importantly look at the sites of action for warfarin and heparin. Let's start by looking at the various components of the clotting cascade, which proceeds all the way down to the final step where you convert soluble fibrinogen into insoluble fibrin. You'll notice that I've drawn a line towards the bottom of this diagram. That's to separate out the clotting cascade from the final reaction shown at the bottom of this figure, which will be the conversion of plasminogen to plasmin. This is the reaction where you're actually breaking up the clot. This is where our fibrinolytic drugs like streptokinase and alteplase are going to work. When you look at the components of the clotting cascade, we divide this into the extrinsic and intrinsic pathways. Both pathways are going to converge on factor 10, which becomes part of the common pathway. You should also recognize that there are a couple of cofactors along the way in the clotting cascade. Cofactors like 5A and 8A. You should remember that both protein C and protein S, which are our body's own endogenous anticoagulants, the way that they work is they can cleave factors 5A and 8A, and by stopping these cofactors, they inhibit the clotting cascade. Now that we've covered the normal parts of this diagram, let's focus on the site of action of warfarin. Warfarin is going to factors like factor 2, factor 7, factor 9, and factor 10. But can you answer this question? Which factor is affected first when you initiate warfarin therapy? That's correct. Factor 7 is going to be the first one affected by warfarin. And we'll talk about exactly why, but it relates to the short half-life of that clotting factor. You might also remember, however, that protein C has a short half-life as well, shorter than some of the other clotting factors affected by warfarin. So not only does factor 7 disappear early in therapy, so does protein C, and importantly, that means you lose one of your own anticoagulants. When you compare the site of action for heparin, you'll notice that heparin is going to work on activated clotting factors. Activated factors such as 2A, 9A, 10A, and 11A. So identifying the site of action is very important, and this figure will help you do that. This table does a very nice job of comparing heparin and warfarin. We're going to start by looking at some of the basic properties, the chemical properties, the kinetics, and the mechanism of action of these drugs. When you think about the chemical properties and the kinetics, it's important to remember that these two drugs are opposite. What I'm saying is, if you learn the properties of one drug, the other drug has exactly the opposite property. If you start with heparin, a very large molecule by molecular weight, it's large and water soluble. It's so large and water soluble that you have to inject this drug. It's so large and water soluble that it has a short half-life of about 2 hours, and it's large and water soluble enough that it doesn't cross the placenta. On the other hand, warfarin is a small and lipid-soluble molecule. It moves easily within the body, so we can take this drug orally. Because it is small and lipid-soluble, it has a much longer half-life of about 30 hours compared to the short half-life of heparin. And being a small and lipid-soluble drug, this drug can cross the placenta. So if the question arises, which of these two drugs is teratogenic, it's an easy question to answer because only warfarin is small and lipid-soluble enough to affect the fetus. When you compare their mechanisms, it's important to think about exactly where these drugs are working and how quickly they're going to have their effect. Let's start with warfarin this time. Simply put, this drug is a synthesis inhibitor. It inhibits the hepatic synthesis of vitamin K-dependent factors. Vitamin K-dependent factors including factors 2, 7, 9, and 10. As we identified on the previous slide, factor 7 is going to be the first factor affected when you begin warfarin therapy. It's the clotting factor with the shortest half-life of these four. Let's get very specific about the mechanism now. What exactly this drug does is it prevents gamma carboxylation reactions by inhibiting vitamin K epoxide reductase. That is the specific target, and by blocking this enzyme, you're blocking the regeneration of vitamin K. Importantly, as a synthesis inhibitor, it has no effect on clotting factors that are already present. That's why this drug is going to have a slow onset. When you start taking warfarin, you stop further synthesis of these 4 clotting factors. But you have to let enough time pass for the existing clotting factors, 2, 7, 9, and 10, to disappear. And those clotting factors disappear according to their half-lives. When we take a look at the mechanism of heparin, heparin is going to catalyze the binding of antithrombin 3. Antithrombin 3 is a serine protease inhibitor. And when you activate antithrombin 3, you're going to rapidly inactivate clotting factors 2A, 9A, 10A, and 11A. So when you compare the onset of action, very important to note that heparin has a rapid onset, whereas warfarin has a slow onset. We'll continue by looking at some additional properties of heparin and warfarin. When it comes to monitoring these drugs, for warfarin we like to monitor the prothrombin time, or the INR. But for heparin, it's the partial thromboplastin time, the PTT. Clinically, we have decided that these are the best monitoring parameters for each of these drugs. Both drugs have their own antidote. For warfarin, it's vitamin K. Vitamin K, which will help you to increase the synthesis of those vitamin K-dependent clotting factors. But you should ask yourself, is vitamin K going to rapidly antidote warfarin? And the answer is no. Warfarin just is going to allow you to synthesize those clotting factors, but it takes time to synthesize new clotting factors. Vitamin K as an antidote has a slow onset. If you get a question that asks you to rapidly reverse the effects of warfarin, you must provide the person with fresh frozen plasma. In other words, you must have clotting factors present in that plasma to rapidly reverse the effects of warfarin. On the other hand, heparin is antidoted with protamine. This is actually an example we used way back in General Principles. You may remember that when heparin and protamine complex with each other, it happens independent of receptors, and that type of antagonism is known as chemical antagonism. And it happens very quickly. Protamine very rapidly binds up the heparin to stop its action. When it comes to uses, both of these drugs are important anticoagulants. Perhaps you should think about it this way. Do you want rapid anticoagulation, or do you want long-term anticoagulation? And oftentimes we want both. So starting a patient on heparin for the rapid onset and then switching them over to warfarin for more long-term benefit is commonly done. But the uses are very similar, whether it's thromboses or emboli, unstable angina, DIC, PEs. A number of things can be indications for each of these drugs. When you think about side effects, obviously bleeding is a side effect for an anticoagulant. But for heparin, you have to watch out for heparin-induced thrombocytopenia. We refer to this as HIT. We'll discuss the management of patients who get heparin-induced thrombocytopenia in just a few moments on another slide. You also have to be aware of hypersensitivity reactions with heparin as well. For warfarin, there's a slight risk of skin necrosis if you have low protein C levels. We'll also discuss that on a later slide. Make sure you are aware. Warfarin has a lot of potential drug interactions. It's a favorite on the exam for interactions with P450 inducers and with P450 inhibitors. We'll also cover this point in a few moments. Warfarin is small and lipid soluble, can get into the fetus, and have teratogenic effects. That includes bone dysmorphogenesis, so be aware of these properties of each of these drugs. Heparin is a large molecule by molecular weight. Being such a large and water-soluble molecule, it has a short half-life. So you should be able to predict. An advantage of using a low molecular weight heparin, a drug like enoxaparin, is that it's going to have a longer half-life compared to the unfractionated heparin. Another possible advantage of low molecular weight heparins is that you don't have to monitor the prothrombin time, or PTT. You give this drug subcutaneously, so you're still having to inject, but with the longer half-life and the fact that you don't have to monitor PTT, these are important differences and perhaps advantages over the unfractionated heparin. When you think about warfarin, always be ready to think about drug interactions. We discussed back in general principles that there are some possible competitions that can take place between drugs that are highly bound to plasma proteins and warfarin because it is also highly bound. An example that we used way back on about page 8 was we discussed warfarin and sulfonamides competing for plasma protein binding. In the presence of the sulfonamide, you get a higher free fraction of warfarin that can enhance the activity and perhaps enhance the risk of side effects for warfarin. That would include bleeding. Also think about what a P450 inducer would do and a P450 inhibitor would do to the plasma levels of warfarin. Let's approach this by thinking about a normal prothrombin time, which is 12 to 15 seconds. A normal INR is 0.8 to 1.2. When you begin warfarin therapy, you're going to prolong these times. So you would expect warfarin all by itself to increase PT and INR. So given that information, what is a P450 inducer going to do to prothrombin time or INR? Since the inducer is going to enhance the metabolism of warfarin, the plasma levels of this drug are going to be decreased. Your prothrombin time and INR will decrease compared to warfarin alone. The inhibitor is going to inhibit the metabolism of warfarin, thereby increasing the plasma levels, and that's going to further prolong PT or INR compared to warfarin itself. Think about how those drug interactions can show up in a test question. Many times it's by looking at these values for PT or INR. In this diagram, we can look at the activation and the role of protein C. Remember that both protein C and protein S are vitamin K dependent endogenous anticoagulants. Ultimately, protein C and protein S are going to inactivate factors 5A and 8A. But think about what happens when you initiate therapy with warfarin. Since warfarin inhibits the synthesis of vitamin K dependent factors 2, 7, 9, and 10, it's also going to block the synthesis of protein C and protein S. And here's what's important about that. We mentioned that factor 7 is the first factor to disappear because it has the shortest half-life. You see from the table that half-life is about 8 hours. But also notice protein C compared to the other clotting factors has a relatively short half-life as well, of about 14 hours. Protein C will disappear after warfarin therapy before the other clotting factors. And what that means is that you can go through a transient period of hypercoagulation. You're going to see a possible increased risk of skin necrosis until those other clotting factors disappear according to their half-lives. Now, you don't see this clinically if you transition properly from heparin to warfarin, if you have enough of an overlap to allow the onset of action of warfarin. But this could happen, possible skin necrosis, with the onset of action of warfarin. Next, we want to look at our direct thrombin inhibitors. These drugs directly inhibit thrombin and don't require antithrombin 3, so their mechanism is different from the action of heparin or low molecular weight heparins. The first drug, argatroban, does not interact with heparin-induced antibodies, and that's why this drug can be used in heparin-induced thrombocytopenia. If you'll notice my clinical vignette at the bottom of the slide, when a patient gets heparin-induced thrombocytopenia, most often this happens because a patient has been on heparin for more than 5 days. This is an immune response, ultimately that can lead to platelet aggregation. So what do you do for this individual? You treat them by immediately discontinuing the heparin, but you still need an anticoagulant. So you switch them to a direct thrombin inhibitor like argatroban, which doesn't interact with those heparin-induced antibodies, has a very important anticoagulant effect at the same time. A second drug, dabigatran. This is an oral anticoagulant that doesn't require monitoring of PT or INR, and it's being promoted a lot today as a great alternative to warfarin for patients with atrial fibrillation. A third drug, bivalirudin, you can use this patient together with aspirin in unstable angina or in patients undergoing angioplasty. Importantly, pay attention to the different mechanism for these drugs compared to heparin. We also have direct factor Xa inhibitors, rivaroxaban and other exabans. As we've gone through pharmacology, we've seen a number of drug names that are challenging to learn. Some of them have been made a little bit easier by common family names. We've seen several examples during our lectures. Well, I will tell you, the name of these drugs is excellent. When I think about exaban, the ending for these drugs' names, it actually tells us exactly how they work because it's XA, which means factor Xa. And what are they doing to factor Xa? They're banning 10A. It tells us exactly what the target for these drugs are. Kind of similar to dabigatran, we don't have to monitor PT or INR with these drugs, so they can also be considered as alternatives to warfarin without that routine monitoring of PT. We use these drugs to prevent DVTs after knee or hip surgery and also in the prevention of stroke and systemic embolism in non-valvular atrial fibrillation.